So now as we shift our focus from a bacterial to a fungal perspective, we have our next speaker, Dr. Dallas Smith, an epidemiologist with the Mycotic Diseases Branch at the Center for Disease Control and Prevention. He is a subject matter expert leading the branch antifungal stewardship activities, and he will guide us through a frequently overlooked area of stewardship. So please join me in welcoming Dr. Smith for his presentations on navigating the fungal landscape, antifungal stewardship in action.
Great. Thank you so much. I'm going to go ahead and share my screen real quick. All right. And I think you are able to see at this point. So thank you so much for the invitation to talk about antifungal stewardship. I'm one of the fun guys and fun gals from the Mycotic Diseases Branch. And so we love talking about fungus. And so I will try not to go over the 50 minutes, but no promises. Also, this is a pretty interactive session. We have several polling questions, and so would love to get your thoughts and your participation. Some of the polling questions maybe have more correct answers. Some are just trying to figure out what the best option is when thinking about antifungal stewardship. But to start out with, fungi are everywhere. They're in animals, they're in the environment, they're in the air. And so this is really applicable whether we're working in inpatient or outpatient settings, as pharmacists, as clinicians, as physicians. And so I'll cover a little bit of both today. We'll start out with some inpatient stewardship and navigating some certain scenarios. Then we'll move into outpatient scenarios and some maybe some resistant bugs or resistant fungi you may not be aware of. But first, just as an overview, antifungal resistance is a growing threat. There's been a lot of media attention about this, either through publication of various scientific articles or just, for example, the hit HBO show, The Last of Us, which I hope a lot of us have seen. I'm a big fan just because, of course, it talks about a fungal pandemic that causes a zombie apocalypse, but also it's a pretty entertaining show. And so several of the fungi that we see commonly are developing resistance, both domestically and globally. Some of the big players include Aspergillus, especially Aspergillus fumigatus, Candida species. We'll talk a little bit about Candida auris today. And then also ringworm or dermatophytes. We are actually seeing this as a huge outpatient fungal resistance concern. And so these fungi are not developing resistance to just one antifungal, but several of these are developing resistance to many different classes of antifungals. And so, of course, we don't have a lot of options compared with our antibacterial colleagues. And so the main classes we have are azoles, echinocandins, pollines, and then some are pyrimidines like terbinafine. And so I'll be talking about different fungi that have resistance to one or maybe several of these antifungals, which is really concerning because we're running out of options to care and treat for patients. Also, in addition to the rising threat of antifungal resistance, we're also seeing new fungi emerge that are intrinsically resistant. And so just in the last year, I just pulled a few publications. These are new fungi that have never been known to cause human infections before. But in the last year, all three of these fungi have emerged, and many of these are intrinsically resistant to our antifungals. And so we're getting these new infections that we don't know how to treat, and we don't have a lot of options, which is really, really concerning and a big stewardship issue. And so when we think about antifungal stewardship to address this rise of resistance, a lot of times it's not on our radars. We think about antibacterial stewardship, antibiotic stewardship, but sometimes antifungal stewardship gets lost in the weeds a little bit. But we do believe here at CDC that it should be incorporated more broadly into antimicrobial stewardship programs. And some of the principles of AMS guidelines that a lot of you practice are applicable to a lot of our antifungal agents. However, because of the uniqueness of fungi and what we're seeing in terms of resistance, there are going to be some unique considerations. I'm going to talk a little bit about these today, but these include just a need for fungal disease expertise and education, interventions to optimize utilization. Therapeutic drug monitoring is actually really, really important for the azoles. And so I know that there's a little bit of this in the antibacterial side, but TDM should probably be routinely done. And then also data analysis and reporting may look a little different than what is on the antibacterial side. And I'm not going to go through this today, but I want to share just a great resource that was published by the Mycosis Study Group a few years ago that developed core recommendations for antifungal stewardship. It's composed of 7 main elements, but even within those elements, there's specific recommendations to meet kind of these goals and these high-level objectives for antifungal stewardship. I didn't want to focus on this today. I want to focus on more in scenarios, but I encourage you all to read this if you're interested in learning more about how you can implement antifungal stewardship at your facility. Um, as I mentioned before, antifungal stewardship is not only needed in inpatient settings, but also in outpatient settings for both superficial and invasive diseases. Um, what a problem we run into commonly when dealing with fungal diseases is that we have poor performing diagnostic tests, and even the tests that perform pretty well are send out tests, and so we have a long turnaround time, which makes antifungal stewardship very difficult. As I mentioned before, we only have a few classes of antifungals, and so our arsenal is limited. And so we really need to conserve and practice really great antifungal stewardship as we wait for new medications or new antifungals with novel mechanism of action to be FDA approved and on the market. All right, so let's talk about inpatient antifungal stewardship. And so this is where I'm going to ask for a lot of your participation. We'll kind of start out with a case report, and we'll kind of discuss some of the challenges and how to navigate these situations. So our first patient here is a patient who develops candidemia, invasive bloodstream infection caused by Candida parapsilosis in your hospital. The patient has had no prior antifungal use. And so my first question to you is with this information, this limited information, what antifungal would you use empirically as you wait for antifungal susceptibility testing results? And so we have fluconazole, voriconazole, ibrexafungerp, micafungin, and amphotericin B. So I'll give it maybe 30 seconds to allow people to answer. All right, I see about 30 people have participated. I'm going to give it just a little more because I know there's about 100 of us on the line. And I see answers still coming in, which is good. Okay, so I see we're about at 40%. Yeah, perfect. Thank you. And so these are really interesting results. So it looks like we're kind of split, but more so, we have 56% of people saying they would use fluconazole empirically to treat this patient with Candida parapsilosis, and then we have 36% who would say to use micafungin or one of our kind of candins as first line. So let's talk a little more about this. So let's talk about Candida parapsilosis in particular and causing candidemia or these bloodstream infections. So our epidemiology of causative Candida species has been shifting in the United States over the last 10, 20 years. And so actually Candida parapsilosis is the third most common cause of candidemia, my apologies, in the United States. It's common in premature neonates, persons with cancer, or COVID-19 and organ transplant recipients. And historically, when we think about Candida parapsilosis, it was mostly susceptible to fluconazole. We didn't see much resistance. However, this is data that we have from our emerging infections program. And so these are sentinel sites all throughout the United States that we use to monitor for antifungal resistance and candidemia. And so this is data for Candida parapsilosis and fluconazole resistance. You can see back in 2008 to 2014, fluconazole resistant rates are pretty low. It ranged from maybe 5 to 4%. You can see starting in 2015 and really increasing in 2023 is that we are up to about 20%, 18 to 20% fluconazole resistance with Candida parapsilosis in the United States. Globally, this is even higher in many places. And so it's a really big concern. And thinking through our therapy and antifungal stewardship, we need to think about, well, empirically, what should we be using first line for candidemia caused by Candida parapsilosis or just candidemia in general? And so when we see these fluconazole-resistant Candida parapsilosis strains, it's often carrying this ERG11 mutation, and this ERG11 enzyme is involved in the ergosterol biosynthetic pathway. Not too important, but I just wanted to give a little background of what we're seeing in terms of the mechanism of resistance for Candida parapsilosis. And unfortunately, what we're seeing now is that we're seeing clonal spread of these resistant strains in healthcare facilities and between healthcare facilities. And so it's kind of behaving like Candida auris to a certain degree. And so not only do we need to practice antifungal stewardship, but we also have to think about infection control and prevention at the same time. And as most of us know, those go hand in hand very commonly in inpatient settings. And so getting to maybe the big point about this scenario and how to navigate antifungal stewardship, echinocandins are recommended as the first line treatment for any candidemia, regardless of species. And what we've seen is that we've seen growing azole resistance observed in several species, not only Candida parapsilosis, Candida glabrata, of course, Candida auris. And so many of our Candida species are resistant to azoles now. Data also suggests lower mortality when using echinocandins. Unfortunately, there was a nice study done by some of my colleagues a few years ago looking at treatment practices in the United States for empiric treatment for candidemia. And we still see about 30% of candidemia treated first line with fluconazole, which kind of goes against what we're seeing from an epidemiological perspective, but also what's in the guidelines. And so IDSA does recommend echinocandins first line, and then these global guidelines that were just released earlier this year recommend echinocandins first line too. All right. And so maybe the take-home point is, of course, use echinocandins first line for candidemia. But maybe the larger picture is that we need to understand resistant patterns and use empiric therapy appropriately, not just for candidemia, but for all fungal infections. Okay, so we're going to our next scenario now, which is a little different. We're still staying in the yeast family. We're going to talk about Candida auris now. But a patient develops symptomatic candiduria. And so this person has Candida in their urine, and they're actually symptomatic. I know sometimes we're not going to treat asymptomatic candiduria caused by Candida auris in your hospital. When we got the antifungal stability testing results, we see fluconazole had an MIC of 64, amphotericin B 8, micafungin had 0.12. And for those who may not be familiar with like the cutoffs, what CDC cutoffs are, although these are not CLSI approved cutoff breakpoints, this would be considered resistant to both fluconazole and amphotericin B, but it would be susceptible to micafungin. A few other notes on this patient. The patient has no reported antifungal use in the past 2 years. There is an ongoing outbreak of Candida auris in your hospital, but in a different unit. The patient also has no invasive devices, including a catheter. And so my next polling question that I have for you all is, what would your next step be in managing this patient? And so the first option is don't give any treatment and see if infection resolves. B, start micafungin treatment. C, ask lab to order additional antifungal stability testing results on other azoles. D, pursue novel antifungals like fosmanogepix. And E, none of the above. Some of you might want to choose more than one answer, and that actually might be correct, but I just want to see what your best choice or your first choice or your top choice would be in this scenario. All right, so I'm hoping to wait at least till 50% or around 50% of people respond. I see it's increasing very quickly this time, which is great. All right, so I think we're about at 50%, and just going over the results real quickly, it does look like the top answer was ask lab to order additional antifungal stability testing results on other azoles, since we didn't have them, we only had it for fluconazole. The next common treatment option is start micafungin treatment. And I'm going to start before going into this case a little more. There probably isn't a right answer at this point based on data, but I'm going to go over a few different options and what we may consider in this situation. And so let's talk about echinocandin. So it looks like a lot of us, 37%, chose that let's start micafungin treatment or echinocandin treatment. Unfortunately, echinocandins have been shown to achieve poor urinary concentration. Interestingly, though, there has been some data that shows that it accumulates like right outside the renal system. And so it might play a role in limiting the translocation of infection from the urine or from the renal system to another part of the body. And there has been some very limited data that shows that mycofungin or echinocandins do treat candidiarrhea. And so that this mechanism of accumulation right outside the kidney may explain how it could treat infection. But for the most part, we normally don't use echinocandins when we do see Candida in the urine, if it's localized to the urine, of course. And one of the things I wanted to point out is that this data is unpublished, but it's from data from the CDC. And this is looking at the epidemiological characteristics of recent echinocandin resistant cases in the United States of Candida auris from August 2023 to December 2024. And so we looked at 93 cases. And I really want to point your attention to the red box here. And so 50% of these specimens of Candida auris was collected from urine samples. And so what we are hypothesizing, and we still need to investigate this more, is that low echinocandin levels, so maybe you're treating a bloodstream infection, but it's also in the urine, there's this low level exposure in the urine is actually promoting development of resistance in the urinary tract. And so, of course, we still need to investigate this more, but the epidemiological data kind of points towards this, that maybe echinocandins truly do not get enough penetration to treat candidiarrhea. And so the other option, which I think more of us chose, was maybe pursuing additional antifungal susceptibility testing results for other azoles. And so this could be a really good option. CDC generally recommend that if an isolate is resistant to fluconazole, it could be a class effect, which means it could be resistant to the other azoles. However, maybe the best practice is to not generalize and still get other azoles MICs. We're still learning more about this. And so although our website says that this might be a class effect, we still think we would recommend to getting those additional MICs just to see what it looks like. And interestingly, we think voriconazole in particular might play a role in some of these C. auris candidiarrhea cases because it gets really good penetration into the urinary tract. And also a mouse model, which of course is very different than humans, but the mouse model has shown similar efficacy against C. auris as echinocandins. And so this is something to consider as you're thinking through how to navigate these difficult stewardship questions, especially with an emerging pathogen like Candida auris. The other thing I want to mention is we do have some of these newer antifungals that are not FDA approved, but they're in phase 3 clinical trials or phase 2 clinical trials, for example. One of the ones that we think is really promising for Candida auris is fosmanogepix, which has a brand new mechanism of action that is not shared with any other antifungals currently. It shows promise in treating Candida auris infections, and it penetrates the urinary tract really well. Data are limited, of course, and so take this with a grain of salt. And if you do want to use this agent, you do need compassionate use IND, and we can of course help facilitate that here at the CDC. But what we've seen is in vitro data has shown very strong activity against echinocandin resistant isolates, and there has been several cases, maybe 3 or 4 cases, treated with fosmanogepix against echinocandin resistant invasive cases that have been treated and shown really good results. And so this may be another option that you can consider in this case when you're thinking about, well, what is going to cause the least harm to a patient and actually help with the infection. And so take-home points, antifungal stewardship is very difficult with a lot of fungi because some of these are emerging like Candida auris and there is limited data. And so we're kind of working off what makes sense mechanistically and combining with what we know clinically, which is usually pretty limited. All right, so on to our next scenario. So we're getting out of the yeast mode. And so we're going to go to mold. I'm not going to tell you which mold because that's part of this process. And so just a little bit about this patient. This is a 64-year-old recent kidney transplant and presents to the hospital with severe pulmonary infection. When you look at the CT scan, you see multiple bilateral consolidations. The patient has a persistent fever. And the patient has already gotten 2 rounds of antibiotics and did not improve on the fever or any of the pulmonary symptoms. Interestingly, we get a beta-D-glucan back of the BAL or which was over 500, so it was highly positive. A fungal culture was taken. Something is growing, but very, very slow, and it couldn't be identified after 1 week. Okay, so that's how you have kind of the background picture. I want to see at this point, you are considering this as a fungal infection because of that beta-D-glucan, a highly positive beta-D-glucan. As you await for that fungal identification from that from the mold that's growing, what antifungal would you start initially? All right, so I'll wait maybe 30 more seconds. Looks like about 40 people have answered so far. Looks like they're coming in slowly, so maybe we can go ahead and close it. All right. So it looks like the top answer here was voriconazole at 42%, but kind of split between amphotericin B, which was given at 36%. Looks like itraconazole, risafungin, and terbinafine was recommended at a lower level. So let's talk through a little more about this case. Let's see what happens. And so the patient continues to worsen after 2 weeks of amphotericin B. So this clinician did decide to give amphotericin B for a presumed invasive mold infection causing pulmonary disease. On week 3 of fungal growth, or 3 weeks later, as this patient continues to worsen, this grows. A very bright purple, kind of like candy looking fungus. And some of you may know this fungus. It's more common than people think, but this is actually Papirosilum elacinum. And for those who may not be familiar with this specific mold, it is intrinsically resistant to amphotericin B. Mold identification can take, on average, it takes about 23 days. And of course, you need to wait for that culture to grow to do antifungal susceptibility testing. And so identification and looking at the susceptibility profile is very much delayed. And so at this point, you're kind of thinking, well, what else could I do in this situation? It seems like most guidelines would recommend amphotericin B in this situation because you have an unidentified mold causing invasive infection, and most molds are susceptible to amphotericin B. In this case, Papirosilum elacinum is not. It is intrinsically resistant. And so this is just thinking through the treatment aspect, of course, but goes back to how important diagnostics are to antifungal stewardship. And so we need better diagnostics to be able to identify the species earlier on. So we could give voriconazole, for example, which has a much better MIC profile and has been used successfully to treat this in the past. And I do want to note that, of course, mold infections are pretty rare in the United States. And you all may be thinking this is a one-off case. Papirosilum elacinum is not very common. It is actually in the top 5 or 6 causative fungi that cause invasive mold infections. And so this is more common than people think. And so this is a pretty big concern when we think about antifungal stewardship. All right. So before we go into outpatient stewardship, I want to talk a little bit about antifungal therapeutic drug monitoring. And this is really critical for individualized care for fungal diseases when triazoles are used. We need to achieve therapeutic doses, we need to avoid toxicity, and potentially, if we use TDM correctly or therapeutic drug monitoring correctly, we may be able to prevent development of resistance. And so what I want to kind of show here is that we did a big data analysis utilizing administrative data from a bunch of hospitals across the United States. And what we found was that 16% of eligible hospitalizations with posaconazole, voriconazole, or itraconazole had antifungal therapeutic drug monitoring performed. This is a really low rate. It was the highest with itraconazole at about 29%. Posaconazole was only 6%, and Vori was about 18%. At the same time, we also looked at, well, for those who had TDM done, what did those first TDM levels look like? Nearly 1/4 of therapeutic levels were subtherapeutic, and this includes an additional 16% were supratherapeutic for voriconazole. And this is pretty concerning because we see a low rate of TDM done for those who are eligible, which means they were on the antifungal long enough to reach steady state concentration that you would actually perform a TDM level. Coupled that with just a very high percentage of TDM levels that were done being super therapeutic or subtherapeutic, which goes back to the reason we want to do antifungal TDM to improve patient care, prevent toxicity, and to save lives, really. And so we followed up those data with like, why aren't people doing antifungal TDM more? And so we tapped into the Emerging Infections Network, which is this group of ID physicians, of ID pharmacists, of other ID clinicians, and you can ask them surveys on a variety of topics. And so we asked them to identify barriers for antifungal TDM. And the most common reason for not performing TDM was the long turnaround times for send out testing, 48% the difficulty coordinating testing logistics, 39%, so almost half, uncertainty about recommendations, and then 18% mentioned uncertainty about benefits. And so we did a few other things after this. So we wanted to get a more descriptive and more a qualitative analysis of, well, what do people think about antifungal TDM? What are they doing here? And so we conducted antifungal TDM focus groups with pharmacists and ID physicians throughout the United States. And when we did these focus group discussions, 6 themes emerged. And I just want to go through these quickly just to kind of set the stage. But one, there was variable knowledge and experience with antifungal TDM among participants. Two, the people who participated really highlighted the importance of pharmacist and physician collaboration and antifungal TDM. The main motivators for driving TDM were actually more on the outcome perspective, preventing toxicity, rather than preventing resistance. And finally, key barriers, as we saw in the EIN survey, were very similar. A lack of comprehensive clinical guidelines, long lab testing turnaround times, complex testing logistics, and high cost. And then finally, one of the take-home points was that we need more additional clinical data on TDM's impact on outcomes. And so one of the things I just wanted to share, based on all of this data that we've been collecting, we kind of put it together. We reached out to some experts and put together these antifungal TDM infographics. And there's actually 2 different ones. The one on the left kind of talks about, well, how to perform TDM in an adult patient. So what antifungals, when should you do it, et cetera, et cetera. While the second one here is, well, you get the TDM result back. What do you do with it? How do you adjust the dose? Is it subtherapeutic, super therapeutic? And so I really encourage you all to, if you're interested in this, I'll put the link in the chat afterwards. Really encourage you all to download these infographics, see if they're appropriate for your facility. And of course, you can always take whatever data information's on here and turn it into a facility-specific protocol as well. All right, so we talked about inpatient antifungal stewardship. We navigated a few difficult cases. Let's turn to the outpatient study now. We'll start with ringworm or dermatophytosis. So again, going to start with a case. And so a 26-year-old man presents to a primary care clinic in Tucson, Arizona. The chief complaint is an extensive rash on neck, abdomen, thighs, groin, and buttocks. So really, most of the body is covered by this rash. And it started about 3 months ago. You can see some pictures of this rash on the image to your right. The past medical history of this patient indicates the patient is relatively healthy, HIV negative, no chronic diseases, no family history of hypertension or cancer. With the available information at this point, what would be your next step at the facility? A, take skin scrapings and examine under microscope on potassium hydroxide wet mount. B, prescribe antifungal corticosteroid cream to cover fungal and non-infectious skin conditions. C, obtain further patient information like social and travel history. D, none of the above. All right, I see lots of answers coming in. Looks like they're still going up, so I'll give it a few more seconds. All right. So it looks about a 50% or 40% people participated. It looks like the most common answer was obtain further patient information like social and travel history. And then the other two answers that were kind of evenly split were doing skin scrapings and doing direct microscopy. And also the other one was prescribing antifungal corticosteroid cream to cover both fungal and non-infectious skin conditions. So let's talk a little more about this. And so upon patient interviewing, so I think this clinician took your advice or 64% of your advice and did obtain additional information. You do learn that he has denied any sexual intercourse with men. He traveled to Bangladesh to visit friends about 6 months before coming to the clinic. And interestingly, the rash did start while in Bangladesh. He has already taken the following medications with no resolution of symptoms. And so this includes hydrocortisone cream, clotrimazole cream, and also 4 weeks of oral terbinafine, which is from another provider. As I mentioned, no improvement in the rash at this point. And so you're struggling. You think this might be a dermatophytosis. You think this might also be a non-infectious skin condition because really no antifungals are working. And you actually stumble upon this CDC health alert that came out in 2023. Um, and it's talking about antifungal resistant ringworm infections. And from this health alert, you actually learn about the spread of a new species of dermatophyte that is resistant to both topical antifungals and oral terbinafine. In the health alert, you also learn how to test for this. And so you do actually obtain a culture from skin scrapings and send it out to the appropriate lab, which are far and few between in the United States that can do this advanced testing. And so this advanced testing takes maybe a few weeks of time. And so from the health alert, you get connected with this website from the American Academy of Dermatology that kind of talks about, well, with these drug-resistant dermatophytes, what should you be treating with? And so based on this, you do start itraconazole. A few weeks later, based on your reading, and you kind of assume at this point, the laboratory reports that the culture was identified as trichophyton endotineae. So let's talk a little more about this emerging dermatophyte. But before that, let's see if you've heard about it before. So this is my next polling question. Have you heard, suspected, or diagnosed trichophyton endotineae before? 1, yes, I've diagnosed. B, I've suspected. C, I've heard of trichophyton endotineae. Or D, no, I've not heard of this dermatophyte before. All right. So it looks about 50% of people answered, and it looks like the majority of us have never heard of trichophyton endotineae before. 21% said they have heard of it, and there was no results for the other two questions. So let's talk a little more about this dermatophyte. So just in general, when you think about dermatophytosis or tinea, ringworm, with lots of different names for it, it's estimated that 20% of humans will have this during their lifetime. You don't have to share this, but when I was younger, I had it. I wrestled for a few years when I was in middle school. I got ringworm from who knows where. And so I had ringworm. I'm sure many of us on the call have had ringworm at some point in their life. It's caused by fungi that invade and grow on the skin of mammals. And so it doesn't really cause invasive infections. It's really just going to be a superficial fungal infection. It spreads really easily, especially through fomites. So person to person, animal to person, surface to person. And it causes itching, scaling, and ring-shaped lesions, which is why it's called ringworm, although the worm may make you think a parasite, but it's actually a fungus. And so when you actually need to diagnose dermatophytosis, visual inspection alone is often inaccurate. And so testing is really critical because just clinical diagnosis, you're going to get confused with non-infectious etiologies because these fungal and non-fungal rashes look almost exactly the same. And studies have shown frequent misdiagnosis even among dermatologists who specialize in this, which of course you're going to treat non-fungal rashes and fungal rashes very, very differently. And so it leads to inappropriate treatment. diagnostic testing, including just a simple microscope, can be critical to actually get the right diagnosis and start the appropriate treatment. Other things like culture and PCR can help as well. And for dermatophytosis in general, it's pretty easy to treat once you get the diagnosis. Usually topical antifungals like cotrimoxazole is it's pretty effective. You just apply the cream for a few weeks and it goes away. Severe infections, you do need to take terbinafine, oral terbinafine, which is a pretty safe drug, really no drug-drug interactions, pretty easy to take. Other things that have been used as greaseprevin and azoles have been used as really, really rarely. They really haven't been needed to treat ringworm or dermatophytosis in the past. Unfortunately, this new fungus, this Trichophyton antinia, is spreading rapidly throughout the world. It kind of emerged in India or in South Asia in general. And you can see this is not your normal ringworm. Ringworm, you see like a patchy of a little round thing on your arm, you have a little squiggly. This is full body, multiple body parts are affected. It's very stigmatized, it's very uncomfortable, and it's very difficult to treat. And so we think topical antifungal and steroid stewardship is critical to the emergence of the superficial fungal disease. Now, I'll talk a little bit about why that is. And so we actually think the misuse of these combination products, these antifungals, these corticosteroids, and even in some places in the world, they combine antibacterials in there too. So 3 in 1 sounds great, but it's actually leading to the emergence of these resistant dermatophytes because when we put the steroid on, we're not allowing the immune system to clear the fungus completely, but we're also exposing the fungus at the same time to an antifungal, so it develops resistance over time. And so this is kind of it makes sense that we want to cover both non-fungal and fungal rashes, but we're actually causing resistance because of it. All right, so that was a little bit about ringworm. I didn't give any data on Trichophyton antinia in the United States, but it is spreading rapidly. We're seeing just cases pop up every week or every day, and it's just spreading person to person. And so it's really going to be a big public health problem in outpatient settings. If you haven't seen it yet, unfortunately, we may be seeing it soon. So stay tuned in your local community because it is going to be probably a large problem going forward unless we are able to address and use antifungal stewardship and corticosteroid stewardship to lessen the spread and really treat patients appropriately. All right, so moving from ringworm to another superficial fungal infection, vulvovaginal candidiasis. So this is a huge women's health issue. We think there's estimates that 3 out of 4 women will have vulvovaginal candidiasis at least one time in their lifetime. That's a really high percentage. You don't see most diseases affect 75% of a population. And so before I even go into talking about vulvovaginal candidiasis and resistance, I want to ask a question about how you would diagnose or how have you seen it diagnosed if you're a pharmacist or someone other than a provider. And so how often do you perform diagnostic testing for vulvovaginal candidiasis in your clinic or pharmacy? And so 1, never, B, seldomly, C, how about half of the time, D, frequently, or E, always. And this is more than just clinical examination. This is actually whether it's a culture, a vaginal swab, an actual diagnostic test. All right. So it looks like the majority, the highest number, have never ordered diagnostic tests or never see diagnostic tests for vulvovaginal candidiasis. The next highest was seldomly, and this is kind of what tracks what we see in the United States. Diagnostic testing is rarely done. And so, as I mentioned, less than half of women with VVC are diagnosed with a lab test. And as a lot of us know, vulvovaginal candidiasis looks very similar to bacterial vaginosis or just other non-infectious causes of vaginitis. And so it's really hard to distinguish based on clinical examination alone. When we think about treating vulvovaginal candidiasis, uncomplicated VVC, which means it's mild to moderate in severity, it's likely caused by Candida albicans and normally occurs in immunocompetent women. But there's also a subset of women develop complicated VVC or complicated vulvovaginal candidiasis. This can be recurrent, this can be severe, and normally this is caused by these non-albicans species. And this occurs more commonly in immunocompromised women, women with diabetes, but also can occur in immunocompetent individuals as well. And so the treatment of VVC is for uncomplicated VVC. It's pretty simple, short course formulations. Usually you give fluconazole, maybe one, of course, take one tablet a day. 3 days later, a week later, you take another tablet. And usually that's pretty good. 80-90% of patients will resolve, the symptoms will resolve from that. Complicated VVC gets very, very difficult to treat, though. Recurrent VVC in particular might require maintenance regimen, so you have to take fluconazole once a week for a month at a time. An immunocompromised woman might not respond well to short-term therapies, and so you may have to take antifungals for months to maybe even years to treat some of these really complicated VVC cases. And I really want to talk specifically about recurrent vulvovaginal candidiasis. And this is defined by 3 or more episodes in less than a year. It affects less than 5% of women, but 5% of women, that's still a large portion of the population. And unfortunately, what we're seeing is that a lot of these are caused by non-albicans species. And these non-albicans species are oftentimes inherently resistant to fluconazole. And so we're giving women 3-4 rounds of fluconazole trying to treat this vulvovaginal candidiasis that's caused by maybe glabrata or maybe rhabdolosis, and it's just not effective. And so we eventually get to the point where we have to move to different treatment options, but this is usually months down the road, and these women are suffering and suffering and suffering. And so some other options that we have includes oral fluconazole weekly for 6 months, but although we still have to think about that resistance issue. And so we're having to get to this point where we're using boric acid or some of these newer antifungals like oteseconazole or abrexafungin. And so we need to think about stewardship when we think about these superficial fungal infections. We're seeing increase in resistance in ringworm, increase in resistance in vulvovaginal candidiasis. And so I just want to share some take-home messages about these superficial fungal infections. These are common in the community. A lot of us have maybe had one of these in our lifetime. Our patients have them. They're not rare like we see with most of our fungal infections. Not many of us are ever going to have an invasive mold infection, but the likelihood of us having ringworm, our children having ringworm, our spouses having vulvovaginal candidiasis is pretty high. We are seeing increasing resistance in superficial fungal infections, both with VVC and in ringworm. Diagnostic testing, I know I've said this several times today, but is a critical component of antifungal stewardship. We need to confirm a diagnosis so we're not giving these combination products of corticosteroids and antifungals, which actually can make a patient worse and lead to resistance. All right, so just a few resources that I want to share before I wrap up my talk. The first one is we have a new service here at the CDC that's called the Clinical Consult Service for Fungal Diseases. And so we will hop on a call with you if you're having a difficult to treat patient or just have a question about diagnosis. And we'll connect you with expert mycologists, either domestically or globally, depending on the fungal disease. And we will talk through things with you and think through the best route in terms of treatment and diagnosis for the patient. You can email us at fungalconsult@cdc.gov. We respond 24, 48 hours, and we'll get you connected right away. So I want to share that first. The other thing that just came out recently, which we're really excited about, is the mycosis study group had this website called Dr. Fungus. We have lots of puns in the fungal world. We love it. But they actually just migrated the website to a mobile application for your phone. And it's a really great resource, especially if you need more in-depth information about treating a fungal disease. We love our CDC web pages, but we can only put so much information on there. This Dr. Fungus really complements our CDC web page as well because they really go into the treatment, some of the microbiology of these fungi and fungal diseases. And so it's a free application. Really encourage you all to check it out. And with that, I'm going to wrap up. I just want to thank the entire ADHS team for inviting me to talk today and thinking about fungi. If I have one take-home message for all of you today is think fungus, no matter what the situation is. We really appreciate the opportunity to talk about fungal diseases. Happy to answer any questions and connect with others afterwards. But thanks again.
Thank you so much, Dr. Smith, for a wonderful presentation. I actually learned a lot about the new, like the antifungal stewardship. very eye-opening for sure. And we have one question, actually two. So the first question is, do you anticipate the CDC will propose breakpoint for CRS and Iprex for the Ipresafungerp or Resafungin?
So we are actually in discussions with CLSI, which is like the main entity that proposes breakpoints for fungi and bacterial in the United States, about developing CRS breakpoints officially. And so we hope that it kind of migrates over to CLSI and that they may take this on. Right now at CDC, we're actually not working on breakpoints for Brexafungin or Risafungin, but we are working on epidemiological cutoff values, which is kind of the next best thing for thinking through treatment options and monitoring for resistance. Unfortunately, epidemiological cutoff values are only based on in vitro testing, only in MIC data, while you need breakpoints. For breakpoints, you need that clinical data, which is really lacking right now. And so stay tuned for more. I hope to have more news soon, but we do realize there is a gap, not only for breakpoints for these new antifungals like Abrexafungin or Resafungin, but also for the other antifungals as well.
Thank you. And then we have a lot of comments say this is an excellent talk. And so thank you so much again. We actually have one more question from our audience. So how can clinicians be better supported in choosing initial antifungal therapy when resistant patterns vary significantly between species and diagnostic are often delayed or unavailable?
Yeah. And this is a very difficult question because, as you mentioned, Priscilla, a lot of our diagnostic tests either aren't very good or, as you mentioned, there's a long turnaround time. And so what we really recommend is that really think through the clinical presentation, think about guidelines. I think one of the major steps I think we can improve as stewardship folks on this call is for candidemia, let's give echinocandins first line. You may assume that this is caused by maybe Candida albicans, for example, but we just don't know. And so we really need to think through like a good first step to practice antifungal stewardship in inpatient settings is for any candidemia, let's give echinocandins. But also, I think the other thing is just to think fungus. I think lots of times it's not so much selecting the initial antifungal therapy, it's just thinking fungus in general. Usually, sometimes by the time we do identify fungus, it's almost too late for patients to recover. And so the other thing I just really encourage us to do is think fungus early on. That doesn't mean you have to give an antifungal, but order a fungal diagnostic test, especially if patients are not responding to one round of antibiotics. Don't wait 2 or 3 or 4 times of giving some type of antibacterial before just ordering or thinking fungus.
Thank you so much. Okay. And I have a question myself, and this may be like kind of repetitive, but I just want to like have like this take home point for our audience. So as you mentioned, antifungal stewardship is often less developed than antibacterial stewardship. So in your opinion, what are the key differences and unique challenges in implementing a antifungal stewardship programs?
I think one of the key challenges, I'll start with the challenge first, is that fungal disease expertise is not taught well in schools. I'm a pharmacist by background. I think I had 1 day on antifungals. And so I think the one of the biggest challenges, one, having that expertise at a facility. Even some ID physicians don't have a good handle on fungal diseases because they weren't exposed, they weren't taught based on whatever it may accomplish. So I think one of the challenges is how do we increase and improve fungal disease expertise at more facilities throughout the United States, especially outside of these big academic centers where a lot of the mycologists kind of flock to. And so I think by doing that, I think we need to think through more continued education. I think we need to better incorporate this into medical school, pharmacy school, nursing school education. I think that's going to be one of the best interventions because if that knowledge is carried on, they're going to think fungus and they're going to be able to like think through antifungal stewardship and implement it well. I think we have a lot of diagnostic tests that are coming onto the market soon. We have some promising LFAs or these like point of care tests. And I think we really need to think through how we adopt those and how we incorporate that antifungal stewardship programs. And so I don't know if that's a challenge or maybe just like more of an ask is like, how do we better incorporate that? The other thing I really we have to think about going forward with antifungal stewardship is what do we do with these new antifungals that are close to becoming on the market? We have a new mechanism of action drug, a lorifim, which looks really promising for a lot of different fungi, especially non-Candida species. We have phosphoenergetics, which I've talked about. I think we're going to have to think about antifungal stewardship differently and more similar to antibacterial stewardship as we get phosphoenergetics on board first. Are we going to be using that more empirically for a lot of fungal diseases given its broad spectrum? And then when we get results back, we have to do step down therapy. We haven't really thought about that in the past with a lot of our fungal diseases because we had such few options. And so I think we'll have to have a dramatic shift in how we think about antifungal stewardship going forward. And looking forward to having that conversation with you all in Arizona or anywhere in the United States or globally.
Thank you so much. That is a really great answer. It's a lot more than I anticipated, but thank you for always like so sharing your expertise. And I actually have one more follow-up question because you keep giving this a great answer. So I guess my last question is, at one of the slides you mentioned how we have still have a very low implementation or uptake of the therapeutic drug monitoring for antifungals. And like you mentioned as well too, is like we have more of those like large academic centers that have more of that ample resources. Reflecting back to my background in training that I was at a community hospital, how would you think maybe the CDC or from like the public state can help support that therapeutic monitoring aspect, like meaning like getting the buy-in from the C-suite and actually get like FTEs or some more resources? Because I think that is always a big challenge.
Yeah, and we've tried to address some of those barriers that we've identified with antifungal TDM. We developed those infographics, which we think is a really great tool. The biggest hurdle, though, that we've been struggling with here at CDC is how do we decrease the turnaround time? If you're
Mm-hmm.
waiting a week to 2 weeks to get a TDM level back, how do you act on that? The level will probably changed. It's really hard. And so we've been talking to see if we can develop more point of care tests for antifungal TDM. And so hopefully we'll have some good news to share in the coming months to years. But really, like, I think the biggest step that most people can take is having a protocol in place at their facility, making sure they know and talk with their laboratory about where do they send antifungal TDM to, since most of it is a send out test. And seeing if there's a closer place that can have a better turnaround time, having some of the logistics in place that will maximize how well you can utilize that level, I think is really, really important. And I think that's really a good role for pharmacists to play in particular, because we are good at those logistical things. We can talk through like, well, is there another facility we can have a contract with that could increase or decrease the turnaround time so that's more actionable while pairing it with a protocol in place about when to do TDM and how to adjust the dose of a antifungal when you get the TDM level back. But I do agree the biggest hurdle is that long turnaround time, the lack of a point of care test, and we've been pushing for it. And so hopefully we'll have some progress soon, I hope.
Wonderful. Thank you so much for entertaining all my questions so far. Is there any other question from our audience? All right. So thank you so much, Dr. Smith, for your time and your enthusiastically, as always, for like really provide a lot of great education to our attendees, including myself.